right? So we all have those patients that have what we call a lower threshold of pain, where they have a high pain sensitivity, or sometimes we call them, some patients have been called histrionic because they're over dramatic to low levels of pain stimuli. And so the result of that in many cases may be a problem within the prefrontal cortex with assigning a proper value. And so we want to talk about at the end, how can we use technology? How can we use new treatments to try to prove that is part of a global holistic care plan? So when you have that happening, you're going to have dysregulation between your ability to handle chronic pain and your changes within your social and emotional status. So physical pain, we know a lot of people with chronic pain have a very, very high likelihood of depression. There's a variety of reasons for that. Part of it is that we're changing the amount of serotonin and norepinephrine that's being released within the central nervous system. Serotonin is one of the essential neurotransmitters within depression. That's why most antidepressants seek to increase that. Norepinephrine has an effect on mood status as well, and norepinephrine also has an effect on nerve-related pain disorders. So there are a lot of different medications that we use for nerve-related pain that focus on increasing norepinephrine. And so if you have a mood condition that affects that, you can see how if you lose norepinephrine, you could potentially increase nerve pain inherently due to that change in neurotransmitter. Chronic pain is a predictor of depressive morbidity. People predisposed to depression or have depression are more prone to relapse, and they have to also be careful of all the different triggers. As they get better at handling depression, they also understand some of the triggers that set those things off. And like we talked about, depression can cause physical pain. So it can lead to physical and mental pain with a decreased overall tolerance to pain. And the depression usually will, in some form, exist among pain patients in about 2/3 of that population. So there's a huge, absolutely massive unmet need for mental health in the general population, but especially in the pain population. And so that's what prompted us to really seek about adding that to our practice. So what are we going to target? What are we targeting here? What are we trying to modulate or change? And so some of the psychological targets are to work on the biologic and physiologic responses. So when you feel pain, your heart rate goes up, but you have some control over that behaviorally, right? And so then we're going to work on psychological and behavioral systems, and then we'll also look into your social support systems. So what are you doing with your circle, and what does your circle look like? Because that's also important, and it doesn't get touched on a lot. The more if you have pain and you have depression or anxiety, your likelihood to have a smaller and smaller social circle or a shrinking social circle goes way up. And you need them. You need that support system. It's just as important as medications and counseling and technology and everything else. So the biologic or physiologic system, one of the big theories, so Melzack and Wall are two scientists that won a gazillion awards from doing some fantastic research on this gait system. And I thought this was amazing. I did some research when I was at University of Virginia as a medical student on different seizure medications. We did a study on seizure medications and how those seizure medications could result in numbing if you injected them into the spot that hurt, and they had a local anesthetic effect like lidocaine. And so we had some amazing data that was published with our rat studies. And so it just goes to show that gate theory, if you can shut off a gate, and these gates are things that are in the large nerve fibers of our nervous system. And so you have a pain that can say you get banged on the toe, and that transmission of that signal is going to go from the toe up the nerves of your leg to one of the nerve centers within the spine and within the large nerve. It's called the dorsal root ganglion. And there are gates there that your body can shut off to say, you know what, I don't want that signal to get propagated back to the brain. It's not super important. I don't want this noise to happen. And if you have a dysfunction with the gates, then you could have more pain transmission. Or if you're genetically inclined to not close off gates as well, then you might have more pain transmission. So it's a phenomenal theory, and a lot of drug development has been based off of this theory. In terms of the psychological and behavioral targets, so we talked about fear-based behaviors. So you're going to be fearful of doing something that could make the pain worse, and that is going to result in you losing productivity at work and also losing the ability to complete activities of daily living. And so we want to work on that. We want to improve that. There's also learned helplessness. So you want to unlearn that. You want to take away that feeling of I can't get better, or this will always be this bad. Trying to rechange that thought pattern. We talked about emotional dysregulation. We talked about perceptions of yourself. Maybe you have a negative perception now of yourself because you always think of the past. We're going to talk about a case where someone had a perception of themselves as 100% healthy. Something happened to them, and now they're always thinking about that past self, and they're not able to get into the moment. They're not able to realize that what they have is getting better, but maybe they won't be that past self. They've got to reshape their own perception of themselves. And then insomnia. We know sleep is crucial to a lot of things in health. High blood pressure happens when you don't get enough sleep. You have a higher risk of obesity, depression, morbidity, diabetes, cancer. So sleep is essential. We all are probably not getting a lot of great sleep because we have so many distractions in life. And then you compound that with stress and pain. So also focusing on the patient's sleep behaviors, focusing on their sleep hygiene is also a big part of this. And so perception is reality. So if you have that patient who doesn't perceive themselves as they are, if they perceive themselves worse than they are, then that's going to become their new reality. And trying to retrain them out of that is a big part of what we do. And that perception of failure. So, maybe I'm not working, and maybe my significant other is working more, and I feel guilty about that. So there's also that sense of, I'm supposed to do this, and I'm supposed to do that, and now I'm not, and that's compounding the issue. So helping them understand that and helping them get past that is a big road to recovery. So social implications. So they're going to lose connection potentially with their social circles. And that support system that we all rely on normally, you need that even more when you're least likely to want to engage in it. And you may feel guilty about reaching out to your friends or your family, or you may feel that you're not fun anymore, so I'm not going to hang out with these people. And if anything, we always say when you're feeling, when you have a mental health issue, when you have a physical issue, those things are even more important. So pushing and prompting and encouraging and helping them understand the importance of those things as a part of their treatment. Engage that as part of their treatment. Really get back into your social circle. Be it your church, be it a club, be it a hobby. Make sure you're still trying to participate in that. Because otherwise, what happens when you don't have those things to fill your day, what do? You ruminate. And that rumination causes that negative feedback, that catastrophization, right? So how do you target these things, right? How do you target them? So I'm going to read off this. This is the example of Noah Smith. So Noah Smith worked as a police officer for 10 years, and he had an accident that left him with severe back pain and vertigo. And so he reported to his physicians, I just want to get back to my old self. I just want to get back to my old self. I'm so tired of being out of work. My wife is working double shifts, and it hurts to see herself, see her push herself like that. But after extensive treatment, his doctor informed Noah that he was likely to never improve beyond his current point. And that's a tough thing to say to a patient. But we have to set realistic expectations. That is so important in what we do. And he told Noah that he couldn't return to the force. So Noah entered an integrated biopsychosocial pain management program where he was assigned a behavioral pain specialist that helped him process the loss of his career and reshaping a new identity for Noah. And so Noah realized that he couldn't go back to work as a police officer, but he began to work on building up more realistic expectations for himself and his future. And he went back and he constructed a list of things that he could do without pain, and what he was able to do in moderation with little to no pain, and what he would need to realistically avoid to not further worsen his injury. So they used that to tailor his interests and abilities to provide a roadmap on where to go in life. He eventually did return to work, but not as an officer. His abilities and inabilities, combined with the need to help people, shaped and guided his career into education. Noah now works full-time. He works at a troubled youth center where he teaches math, and he acts as a volunteer counselor. So, you know, he has a promising life, and it's a very rewarding life. It's just different. He reports high levels of satisfaction, and despite missing working on the force, which is normal, he says he wouldn't change a thing. And so that takes time. And so we have to give our patients the roadmap and the time to get to where they need to be so they can still be productive members of society. So that goal is self-efficacy, confidence in the ability to exert control over one's motivation, behavior, and social environment. And this is a whole thing that's called reestablishing your locus of control. You know what you can control, focus on that. And that's part of focusing on the positive things in life. Focus on what you can control, and don't worry about those things that are out of your control. And there's a wise saying of, don't stress. If you can control it, why stress about it? Just do it. And if you can't control it, don't stress about it. You can't fix it. And it's an easy thing to say. It's a hard thing to practice, and it takes a daily mantra almost to get there. So recovery. So the conventional thoughts and beliefs are to treat the injury or diagnosis, the physical problem, right? Which we've all been doing in our practice for many, many years. That's what we've been focused on. Give them therapy, medications for pain, do an injection, do a surgery, do something to treat the physical problem. And once they're pain-free, case is closed. But maybe it isn't, because they still didn't go back to work. They still weren't productive. And why not? Well, you didn't address the full patient. So a holistic recovery model is treat and support the person. Treat the person, not the pain. And the same thing happens when people get MRIs. And we always teach residents and fellows, we always tell them, don't treat the test, treat the person. Don't look at an MRI and then make your diagnosis off the MRI. That helps you, but it's not end-all be-all. Non-pharmacological relief. So the other side of this is when we do a lot of mental health therapy, a lot of it is focused on either a lot of heavy use of pharmacological agents. And those are helpful. I mean, you have physical neurotransmitter changes. Those are helpful drugs, but that shouldn't be 90% of the therapy. There's got to be a holistic model here in terms of looking at lifestyle changes and looking at their behavior and helping them from a counseling and hopefully a technology standpoint, using all those together. They all work well. Assist beyond the pain relief. When the patient is whole, then the case is closed. Interacting with the patient. So sometimes, if you're doing a procedure on a patient and then they come back and they say they still have pain, you also have to be careful on how you don't transfer your thoughts, right? We also teach physicians and clinicians not to react to that patient, and you might have an internal thought pattern that might come across to that patient, and then they won't be compliant. You won't build trust, you won't build rapport, you won't help them to where they want to be because they think you're not invested in their care. So non-judgmental care, expert to expert, so building that team of specialists, strength-based programs, working off that positivity angle. What can you do? Empowering them to do more, preparing them for the path ahead, and then instilling confidence in them so that they can continue to do that. So the dominant narrative, so this is what I've been talking about, reshaping, becoming more positive in your thought patterns. So if the dominant narrative in their head is negative, that's going to control everything. And so part of that intensive therapy is to reshape that narrative, make the dominant narrative a positive. In terms of models for psychological and behavioral pain management, a big part of it is mindfulness, understanding and being aware internally when you're having those negative thoughts. Because to get the dominant narrative changed, you have to know when the negative thoughts are happening, and you have to act on them internally, and that's part of that training, part of those mindfulness programs from a cognitive behavioral therapy standpoint. Then there's acceptance and commitment, just like we talked about Noah. At the, towards the end stage of his treatment, he had gotten to a place where he accepted his new reality, and he was, committed to making that reality a successful one. So that's a big part of it. And then pain coaching them through when pain happens, how do you use your mind, and how do you use all of the other physical treatments and incorporate them together to have better success. So mindfulness is the ability to pay attention to something in a particular way, on purpose and without judgment. It's a tool and not a goal. The idea here is that you're getting control of cyclical thoughts, control of anxiety, pulling attention away from pain and increasing functionality. So it's a very powerful program. And again, these kind of things are helpful for everyone. We all would benefit from this. Cognitive behavioral therapy and mindfulness integrated cognitive behavioral therapy is meant to treat pain. It's meant to treat fear responses, things where, again, those patients may not want to do things that may increase their pain, help them navigate through that so they're more active, and stopping that thought pattern that, this is going to be much worse 10 minutes from now, and then making those neurotransmitters release and then making the coping ability go down. All of that is a cycle. So helping them with that. So we talked about acceptance and commitment therapy, people going through difficult changes, pain patients, and patients who are struggling to accept their limitations are all valid patients that we want to treat with these types of treatment plans. Pain management coaching, the key thing there is guiding them to a better reality and having accountability. They have to take responsibility for what they need to do. That is also crucial. There are sometimes cases where we see patients who just think that everything needs to be done by their care team. Yeah, you're going to give me the medicine. You're going to give me the coaching. You're going to give me the injection. You're going to do the surgery. You're going to tell me what to do. And yeah, that's part of it, but it can't be 100%. You have to also tell them, you've got a part to play. These are your responsibilities. I tell my patients all the time, here's your homework, here's your to-do list, and when I see I've got mine, you've got yours. If we do it, we're going to be better for it. And a lot of them respond to that because sometimes just giving them a simple to-do list that they leave with helps them understand all the medical verbiage that we've given them. Hey, you have a disc pathology and a radiculopathy and other Latin terms, and then they go out there more confused than they came in. So helping them with that list is essential. Put it in layman's terms. Other techniques that are beneficial. So we talked about support groups. Make sure they have a support system. Are they in a meditation class? If they need to be in meditation, there's so many resources on the web. I direct a lot of my patients to tm.org. It's a transcendental meditation nonprofit worldwide. They teach a lot of great courses. I tell them to download Headspace. There's a lot of great apps that teach you how to meditate with visual cues. Those are all great things. Yoga and Tai Chi are phenomenal ways to rebuild posture, improve some of those accessory muscles, while also reducing stress in a load-bearing way. And then making sure that they have those social groups that they used to go to, that they go to them even more. I tell them, whatever you did, if you went to church once a week, I want you to go twice a week. If you hung out with your family once a month, I want you to try to hang out with them once a week. Making sure they have things that keep them busy, keep them away from just being alone, on their own thoughts, rumination, idle hands, all that, right? So that's a big part of it. So what are some of the new treatments in psychosocial pain management? So these treatments are, many of them are based on technology. And you'll see some of this technology, if you go to the exhibition booth, you'll see some of this technology being demoed and available. So get your hands on it, try it out. A lot of it's based on virtual reality, and it's really, really cool. You know, I think virtual reality is one of the neatest technologies. I've been using it for over a year now to train other surgeons on a surgical procedure if they couldn't come to us because of COVID. And I think for our patients, different visual stimuli, different programs that we can run through those virtual reality modules that they can put on in the comfort of their own home is going to also reduce that rumination period, right? So if I have access to this technology for my patients, I can say, look, when you start to notice these behaviors, when you start to notice that catastrophic thought pattern, put this on. Put this on and use it right away, and as well as your usual scheduled treatment schedule with that device. So it is, virtual reality is really growing as a modality for lots of different treatments, especially within pain management, because we talked about how the prefrontal cortex helps you analyze, helps you value different pain, and helps you make pain sensation. That's where you're going to help rechange the brain. So we're seeing some great technology there. We're seeing some great technology with depression, anxiety to remap the brain in some other ways that are non-invasive. So it's something that I think you guys should check out. It's something that's portable, it's predictable, and it's manageable by the patient. It's easy to use in the clinic and the home setting, and it allows the patient to have a sense of control. It allows them to have a device that they can use when they need it or when they should have it or want it. We always talk about treatment, do no harm, right, in medicine. This is something that has a relatively low side effect or adverse risk profile. So that's also something that we care a lot about in medicine. How do we have cost-effective programs that have less likelihood to hurt our patients? The key thing here is not to use it as a standalone practice, but as a powerful adjunct to a holistic pain care management program. And we talked about the different types that are available. We have mindfulness integrated virtual reality, we have distraction-based virtual reality therapy, and we have combined behavior and mindfulness virtual reality therapy. So we have all three of these different ways to try to help our patients. So the first one, mindfulness, is based off of more of a set pattern and trying to build that regular practice setting of being more mindful. The next one is distraction-based. Distraction-based is more, I think, episodic. So the pain is hitting me pretty hard. I'm going to put this on and try to distract my brain from focusing too much on this. And then the next is that, again, combined behavior and mindfulness, really more of the coaching we talked about, pain coaching, the counseling, plus the use of virtual reality and other technologies to try to help them. And the key thing here is we're giving our patients knowledge. We're teaching our patients ways to think about their pain, ways to control their pain outside of the use of medications and other harmful things. Distraction, we're providing an analgesic effect that could reduce the pain by up to 50%. Why does this happen? A lot of people say, oh, is that true? Is that really a thing? So if you look at every clinical trial is placebo controlled. They give a placebo to patients because we know placebo works 30% of the time. 30%, we get 30% reduction in pain in placebo with clinical trials for drug development. So the mind has a very, very powerful link to the body, and if you can use technology to activate that, to encourage that, to bolster it, then that effect should get even stronger. Meditation, we know it reduces anxiety, stress, depression through programs that are specifically designed for that effect. And escape. We need those patients not to get stuck on thinking about their pain. They need a way to get out of it. And if they're stuck at home, this is a great way to kind of distract them, get them away from that thought pattern. So the key thing here is looking at this as a Venn diagram, looking at this as combined therapy, putting it together from focusing on biological, physical changes, psychological changes, and social changes. You bring all of those together, then you're going to be in that middle part of the Venn diagram where you're going to have the best success rate. So if you guys have any questions, we have our contact information up here. You can call us, you can email us, info@naspacmd.com. We have practices in North, Central, South Jersey. We're on the shore, we're in Pennsylvania, we're in Delaware.